Well, good morning, everybody. We want to thank you for taking the time to join us for another webinar for our primary care partners. Today, we will be going through the low-end non-utilizer program, PAM, and coaching for activation. Just before we start, we'd like to go over some housekeeping rules. If possible, please do not place your phones on hold. Please keep your phone lines muted. And we have planned a time for questions at the end of this webinar. At any time, feel free to use the chat function in the GoToMeeting invite to submit any questions you might have, and we'll be sure to answer your questions at the end of the presentation. So moving on to the presentation, we're going to start by discussing the low-end non-utilizers in the primary care clinics. And we will go through this agenda. As you can see here, I'm not going to read all of it, but this is what we'll be discussing, except for the customer satisfaction. We will not be going over that today, but everything else will be touched on at this webinar. Just for reference, this is a picture of the district calendar and our MPA period. As previously stated, the DY3 year runs from April 1st to 2017 to March 30th of 2018, but the district calendar runs from July 1st, 2017 to June 30th, 2018. In order to accommodate both periods and to merge both periods together, this year's MPA period is running a little bit longer than usual, from April 1st, 2017 to June 30th, 2018. You've all seen this before, just wanted to reference it again. So we're going to be speaking about the patient activation measures and improving patient outcomes and connectivity to primary care. In your primary care MPAs, this is the language that is represented that speaks to the PAM project. It says that you are to administer PAM surveys in the primary care offices. Participants must perform PAMs on a minimum of 10% of Medicaid visits. This is a process measure, and you're supposed to provide workflows and quarterly reporting on the number of PAM surveys that have been administered at your clinic. Now I'm going to turn it over to Rita, who is going to speak about the details of the PAM project. Rita?
Hi, I'm Rita Hubbard Robinson. I'm the director of the Patient Activation Measures Project, which of course we lovingly call PAM. And this slide really gives us an overview of some of the characteristics of PAM. It is a survey that we use to determine the activation level of an individual, and their measurement score would be somewhere between 0 to 100, but their actual level would be somewhere between 1 and 4. If there are 1 or 2, they are disengaged, they're not engaged in their health, they may be overwhelmed, they may be struggling with say a chronic condition and the requirements to manage that condition. If there are 3 or 4, they're taking action, they're engaged in their health care, they're engaged in doing research about their health, they're managing their chronic condition. And knowing this information can be very, very helpful for the practice. So we really wanted to make sure that we convey to the listener, to the practitioner, why this activation process is so important and how it can be helpful to managing and improving overall patient compliance and their performance around their chronic condition, and really getting them into their primary care appointment, either multiple times for chronic condition care or annually for a preventative health screenings and annual appointments. So we wanted to underscore these things. We know that the activation number will allow you to know who needs more support, will allow you to understand what the individual's needs might be to achieve their higher potential around their condition, and also gives you a way to measure the performance of the individual over time to improve quality care. Um, in order to do this project, it would be important for an individual office to have a place within the EMR or EHR so that you can document the level and the score of the individual. And that score is really important because when you engage with an individual to improve their overall patient activation, the score is the number that will probably change greater than the actual activation level. So if you have a person who is a 1 and their activation score is a 25, we expect that because of the actual intentional care to counsel that individual and work with that individual at their score or activation level will change their score over time, not necessarily their activation level. The activation level is a broader number. That number runs from like 1 to 51. So, but we're looking for a change in their scores. It could be from a 25 to a 28. So if you have a place in your EMR or their score, that is what's we're looking to see a change in the score over time. It could be that their activation level could change, but that means that they have to be closer to the cusp of the number preceding the number level of that activation, that person's activation level. So this is our suggestion. It's a draft workflow of how something like this can be integrated into your actual office. This person would be they would take and be administered a survey. That survey would be enumerated. You would be able to know that the level would be a 1 or a 2 or a 3 or 4, so that when this person goes in to see their primary care physician, the physician would see a 1, 2 or a 3, 4, and based upon whether they're in that category 1, 2 or 3, 4, the interaction between the physician or PA or NP would be associated with a low activated person or a higher activated person. If they're a higher activated person, you would probably do what you always do. But if they're a lower activated person, we would suggest that you would modify the way in which you interact with that patient so that they can break off smaller pieces of what they need to do to achieve their overall improvement in their health. And then the actual nurse, case or care manager, educator, after the person sees the physician, would really go over and do the coaching for activation, which we will discuss as well, to help that person improve their overall condition and their maintenance plan. And we would be working to understand their movement, overall movement, on an annual basis and provide you with that information, or you would provide that within your organization, depending upon how you implement PAM internally within the primary care office. I mentioned coaching for activation. Coaching for activation is a tool that's a compatible tool to the patient activation measure tool, and correlates exactly with the 1, 2, 3, 4 levels identified by the person being surveyed and graded, and then the level. This coaching for activation correlates exactly with that. So if a person is a 1, if you go into the system, which you will have access to, you will be able to coach that person at a level 1, a level 2, a 3, and a 4, as indicated here. And each level has goals. So a level 1's goal is to help them to become more self-aware, help them to be more confident, help them to make small steps toward attaining achievable goals. Level 2 helps to, again, improve confidence, help them to master their overall self-management competencies, and to help them to monitor any symptoms, take their blood pressures, take their blood sugars and so on in order to properly and effectively maintain their condition or manage their condition. And then 3 and 4, again, are ways in which we can interrelate with individuals who are higher in their activation level to help them to increase their information around their condition and their maintenance plan.
So now we're going to have Dr. Kenyani Davis, who's going to speak about PAM and coaching for activation from a physician's perspective. Dr. Davis?
Great. Thank you, everybody, for joining us on this webinar. What I want to speak to is regarding PAM and how a physician can use it or how you can implement it within your practice. And I think in order to do that, you have to understand exactly what PAM is and a little bit behind that. So what PAM is, it's a standardized validated survey tool from Insignia Health. And what does it measure? It actually measures the global measure of an individual's overall ability to manage his or her health, which is a very different concept than what we're used to, which is patient comes in, they come in with diabetes, hypertension, or any other chronic disease, we manage it. They come in with an acute complaint, we deal with that. This is different. This is really getting at what level of understanding does this patient have in regards to managing his or her health. In the target population, this actually can be applied to anybody, but really the target populations to kind of really apply this to would be either your non-compliant population, which I struggle with that terminology because I don't really believe in non-compliant patients. I just believe in patients we haven't met their needs yet. But patients with multiple comorbidities or patients with complex histories or a disparate population, these would be a perfect target to actually use PAM for. So the intentions of the survey is to identify and assess the patient's readiness for entrance and engagement into the healthcare arena. That's super important because if the patient isn't engaged or capable of navigating our very, very complex system, it doesn't matter what goals I set forth for them. They can be the best evidence-based practices known to man, but if they're not ready to enter into that arena, it doesn't matter what plan that I put forth. And the goal of it is to change disengaged patients and turning them into activated patients. And that's a very different concept. And it's almost kind of like motivational interviewing, but done in a different light. And what that does for us is it stratifies patients into categories that will enable physicians to build a better rapport with those particular patients. And what that does is it changes the dynamic of having the patient come to us, but meeting the patient at their needs and where they're at and bringing them up to the speed that we need them so that we can start hitting those quality metrics. There's four different levels of PAM, and we'll talk about the different levels and what that means for patient care. But overall, when you look at these patients over the continuum, the scores do change over time, and what that equates to is how ready that patient is to engage into our healthcare system and how they're able to receive the information that we give them at their appointments. When Insignia Health did their research regarding PAM while they were validating the tool, they did note that a 1-point increase in a PAM survey score equals about a 2% decrease in hospitalizations and a 2% increase in medication adherence. May not seem like a lot, but if you have a population of 5, 6, 7,000, that means a lot. And that also is notable for the small percentage of Medicaid population that utilizes almost 95% of the health care. That 2% makes a big difference. This score should be used to provide the appropriate amount and type of support to the individual. So that leads us into kind of how you would use the levels. So level 1 and level 2 are pretty much people who are disengaged and overwhelmed with the system. And it is a complicated system. I have multiple degrees, and I can tell you every time I have to use the healthcare system, I myself am very, very confused. 3 and 4 are your usual patients that come in, and you can give them multiple steps, and they're able to, for the most part, navigate through the system. But really what we would like to do is we'd like to bring these people who are from a level 1 and a level 2 up to that 3 and 4, because that's when you can really start getting the health outcomes that you need. As a provider, one of the ways to use this, and if there's any other providers on the phone or anybody else who's working with providers who have the unfortunate job that they have to come to their providers and ask them to do one more thing, one of the things to tell them, or if you're a provider on the phone, is that this isn't just another thing that you have to do. This is really dichotomizing your workflow. If you see a patient with a level 1 or a level 2, that's understanding that they're not really that engaged in the healthcare system for many different reasons. That could be very multifactorial. But for you as a provider, I know that I just need to give them short-term goals. I can't send them for, a CT scan of the lung, blood work, and a referral for here and a referral for there, and then it's too much. There's too many steps and too many barriers, and and a colonoscopy too. And by the way, they're going to call you with the prep. That's way too many steps. So if I see a patient with a 1 or a 2, that lets me know that I need small steps. Maybe those small steps are whatever point of care I can do in that office right now. If that's a point of care hemoglobin A1C, a point of care INR, I'm going to do whatever I can in that office right then. Then I'm going to give them 1 or 2 goals and bring them back. Or maybe I'm going to do a soft handoff and have a team that's already there, and they're going to do a follow-up call with that patient within 2 weeks to see if they were able to carry out any of the instructions that were given to them during that appointment, and if they need any assistance in that. If you have a level 3 or a level 4, this is somebody who has some self-management skills, and a level 4 is your star patients that I think everybody would either like or possibly get annoyed with, either one. There is a such thing as being too engaged. However, these people can actually take those multiple steps. Go for your DEXA scan, go for your mammogram, go for your colonoscopy, go for your blood work. Oh yeah, by the way, I need you to call your insurance company, see if they do the shingles vaccine, and then go there. These people are able to do those multi-level steps. So for your providers, it's just understanding who gets short-term goals and who gets multiple goals. If you wanted to take a step further in your gold star practice, then there's something called coaching for activation. And when you do PAM patients, there is coaching for activation that if you put in whatever their comorbidities are and whatever level they're at, they will actually give you tools to coach patients at their particular level. And this is an important concept because as we move to a value-based payment, we really need to start meeting people where their needs are at. I know one of the big things is no-show rates, but people don't show up just because they don't show up. There are usually some underlying reason for whether we agree with them or not. There's usually some underlying reason, and until we're able to peel the onion back and get to the root causes of some of these no-shows or why people drop off and why they're not utilizing our services in the past 12 months. And all these things are very, very important things as we move to a value-based payment structure. We have to be able to meet patients at their needs reasonably, but also bring them up to the speed that we need them to be so that we can get what it is that we need out, which is the health outcomes.
All right, thank you, Dr. Davis. Now we're going to move on to the second portion of this presentation where we're going to go over the low and non-utilizer program. Again, per your MPA deliverables, this is what is outlined in your contracts. Under non-utilizer management, you're supposed to contact non-utilizers via telephone call or letter and attempt to schedule an appointment for them. And then if outreach is unsuccessful, being able to hand over these patients to an MCC contracted CBO vendor, which is a community-based organization. And then they're supposed to reach out for the patient on your behalf as an additional outreach. And you as a primary care physician or primary care practice is supposed to accept those non-utilizer referrals from the CBO vendor, and 90% of those must be scheduled within 30 days of that referral back to you. So again, this is a process measure. You're supposed to provide these lists of patients to the CBO vendor, and then we will make sure that we complete an audit either through the finance team or the relationship managers to ensure that you are outreaching these patients and accepting referrals back and scheduling within 30 days. Now I'm going to hand over to Rita to speak to the details of the low and non-utilizer program.
Hi, I'm back again. So this is an example of a workflow that we have created to as a sample of how a primary care office and the CHW vendor or CBO vendor would interact with one another in order to accomplish this goal. The ultimate goal is to A, improve the numerator, and B, reduce the denominator, really getting to those lists of low and non-utilizers who have either not come to the office at all after being referred to your primary care office, to also bring back patients who have not been to the doctor's office over 12 months or more, and to engage them back to the practice so that they are utilizing primary care in an appropriate fashion. So we're asking that you provide a vetting process, going through your low and non-utilizer list, either connecting through phone calls or emails if you have that capacity, or texts and or letters. And this is something that you can work with your relationship manager to determine whether this is a high lift or not, and it's not something that has to happen. It's something that we're suggesting again that would happen, but it's not an all or nothing. So these are things that could be worked to be what your office can actually do. So there is compromise available here. But what we're asking is that you would vet this list for both members that would be in a health home and also those who you might be able to get back to the practice easily. And then you would secure a BAA with a CBO so that you would then be able to give this list to the CBO, who could again make those phone calls to those that did not respond to your letter to invite them back to the practice. They would call those individuals 3 times or more. After that, they'll go to the home and see if the person is actually still there, and really try to figure out whether they should still be on your patient panel. Maybe they've deceased, maybe they've moved on to another primary care office, maybe they are just unwilling to come back. Whatever the situation is, the CBOs would be in a position to go out and find out what is going on with those patients. The contracted CBOs that would be identified based upon their proximity to your primary care office are these CBOs: Healthy Community Alliance in the Southern Tier, National Witness Project in the central area, Niagara Falls in the northern area, GBON and Planned Parenthood also are in the central area. We have also identified where each of these primary care practices would connect with a CBO, and also who the relationship manager is on this slide. So if you are in the Southern Tier, most likely your CBO will be HCA or Healthy Community Alliance. If you're in the northern area, it probably would be Niagara Falls Memorial Health Home. And then those in the central are broken up between National Witness Project, GBON, and Planned Parenthood. This is just an example of how the project will work. I am the lead on this project, and the relationship managers are going to continue in their role with the primary care office and can help with connecting the CHW vendor and the primary care practice in the primary care setting, and of course their responsibilities that the primary care office has and the CHW vendor has as well. Basically, it's a team approach to providing all the support services that we can around that individual patient to get them reconnected back to their primary care home. Again, these are some of the steps kind of called out here. We know that there has to be a BAA between the primary care practice and the CBO. The primary care practice also needs to identify a person to work directly with that CBO representative. The CBO office has to do the same, and then now you have that team. You have to establish a workflow between the two, the CBO and the primary care practice, and that list has to be generated. There has to be a way to share that information in a secure manner between the primary care practice and the CBO. There will probably be a team or individuals who will provide the outreach to the actual patient, and there will be a tracking process and reporting process that the CHW will do. And then, as Sarah mentioned, there will be an audit to determine whether the process actually flowed properly. Also wanted to call this out. We have an expectation that we can get these new or renewed patients back into the primary care office within a 30-day period. And we are also, as a CHW community, as a community-based organization, community really looking to come up with strategies in order to keep these individuals engaged through that 30-day process. We're looking at various ways of doing that, linking people through their cell phones, sending reminders and notices on their cell phones, information about their healthy habits and so on over the 30-year period in order to keep this appointment top of mind. Some of our CBOs are actually providing transportation. We're really looking at ways in which we don't lose that patient once we get that patient on the phone or connect with them face to face. We're looking at various ways to do that. So we know the closest to the point of contact with that individual to the day of their appointment, the more reliable that appointment will be, or more able that person will, see that as an important thing that they need to do. The further out we go, the harder it is to get them back. So we wanted to say that we have an expectation that this is going to be done at least 90% of the time. We're going to get those patients in within 30 days. Also, we wanted to say weekly, if a person doesn't show to the doctor's office, we want to get them right back get that list right back to the CBO so that CBO can follow up with that particular person right away. We're saying to the patient, this is really, really important. So if we don't get back to them for a no-show for 3 months, that it doesn't really appear to be important. So we want to know within a week's time that a person didn't show up for the doctor's appointment, and we want to get back to them right away so that we're still saying the same thing. This is important. This is important to your health, and we need you to get there, and we want to help you get there. We want to remove any barriers. All of those type of things are part of the process that the CHWs and the CBO community will be doing for you to improve your no-show rate and to get back those low and non-utilizers. This is what the CHWs will be pretty much reporting to us on. We can't do it without getting a list from you, and from there they will be providing us with how many individuals per month they have reached out to, how many got scheduled a doctor's appointment, how many no-shows were there, if we know why, and how many appointments were successfully met.
All right, so we want to thank everybody for taking the time this morning to join us. Please feel free to reach out to your relationship manager if you have any additional questions regarding PAM or the low and non-utilizer project. We're happy to provide any assistance and connect you with Rita if we're not able to answer your questions. We want to thank Dr. Davis for joining us as well and taking the time to give us perspective from the physician point of view. So we want to thank you again, and hopefully we will see you back for the next webinar. Thank you.